My supervisors think it's funny. They're like, yeah, Preston likes to explore with like fantasy and imagination with his patients. And I guess I do that a decent amount where like I'll like literally pull up my computer and be like, okay, this new fantasy life you want to live, let's build it right now, like Minecraft.
How to be patient.
Preston, how are you doing today? Where are we at?
Oh, I'm doing fantastic. I had a whole day of didactics, just absorbing information, and now I get to do the same thing in my dedicated role as passenger princess, which I could get used to
Triple
this, I
P.
think.
Passenger princess, Preston.
hmm
Um,
That's
and I
the
get to be in
passenger
control,
princess
which is my
Preston.
preference.
Yeah. Well, everybody's happy.
Everybody's in their designated roles. I don't have an icebreaker for us today. I thought we could just like life check in. Listeners, when we film in advance so that we don't miss any weeks, but we just finished our first week of July. And I wonder how you're doing. I just started a week of fellowship, but how's like life things instead of doing a themed
Oh,
icebreaker?
things are good. So, if you aren't aware, and this is the audience as well, I start third year this year, and that's more outpatient for my program. So there's always 1 year of entirely outpatient psychiatry residency, and our program does it third year. And I kind of like it so far.
Really? Say more.
Everybody loves to be like, oh, like clinic is so boring, and there's like a lot of procedure, like going through the schedule throughout the day. But I own all of these patients now, so I'm like, hey, I feel like their coach. I'm like, we're on a team, all right, and, and I'm gonna see you back in 4 weeks, and we're gonna get to the bottom of this. No problemo. It's like it's fun to feel in charge of people, you know. I've been playing like pseudo responsibility for like
Yeah.
5 years now, but I'm actually feel somewhat responsible for them now. Because before you go into clinic and it's like, okay, do the whole performative like assessment and exam. The attending wants you to present their plan, but they want you to basically just tell them what they want to hear, which is whatever specific plan it is on that day. And then you're like,
Mm.
okay, cool. I'll never see you again to the patient
That's
ever.
real, unfortunately.
And then you go out of the rotation. They're like, Didn't you love outpatient? And you're like, I no.
I
I just followed
love
people around.
being
I was their note monkey, and then I
love
never saw the patients
shadowing.
again. So
My passion isn't for medicine, it's for shadowing.
yeah, dude. Nothing, not that I love more than watching someone do their job and then write their documentation.
Nothing like it, fellas.
So I think I was like prepared to not like outpatient. Then I was like, oh wait, I actually get to be a doctor. So that's kind of nice.
Are you doing like a lot of intakes? I feel like that's like the positive view of it. And like the other view of it is like, oh shit, these are my patients. Like these are mine. Like I'm the person who like talks to them the most. And so I feel like that transition is like exciting and like, yes, finally. And then
Hmm.
it's like also with that, the dual sidedness of responsibility. Have you been feeling any of that or do you feel pretty
No,
well
I hadn't
supported?
even thought about that yet. I'm like, oh, they are my
You're
patients.
like, no, wait a minute. Preston just
There's
gained
another side to
consciousness
this coin.
in your eyes.
Yeah, I think maybe this is just like my delusional confidence or something, but I feel like I've always been wanting to take on more responsibility
Mhm.
in psychiatry, and I don't mean to devalue our profession, but I think sometimes I'm like, what's the worst that could happen at psych? You know?
Well, I can think of a few.
Yeah, yeah, and we can always think of like the very glaring bad things, but I guess I'm
Mhm.
comparing myself to my sister who works in an ICU.
Yeah,
She's like a crit care attending, so it's
yeah.
like,
Hi,
okay,
Lilac.
you know what I
Sorry.
mean? Like I feel the pressure differential between like
That's fair.
my depression intake and her patient care every day.
That is fair. Hers is immediate. And listeners, I think we've mentioned this before. One of my brothers is also an ICU doctor, and my sister is an oncologist. So I'm not winning any comparison games there either.
Don't complain about call, don't complain about
Don't
your
complain about
schedule.
call. About the emotional impact. Yeah. Love you guys. Shout out. Um, that's exciting. That's good. I feel like there's like a little I listened to our burnout episode because it came out recently and we were in the dumps there. I think that was the end of May.
Yeah, yeah, I felt that. So what's going on with you?
I started fellowship last week. Um, most of it right now is like not patient care issues. It's like get Duo to have two-factor
The
authentication.
Microsoft Authenticator app that
Right, or you get, like, you email someone, you're like, "Hey, this isn't working, it says this error," and then they're like, "Are you sure?" Like, 2 days later, and they email and you're like, "I am, can you just I'll take care of it if you just give me a phone number for someone." They're like,
uh,
We're thinking about this," and I'm like, "I needed this yesterday."
oh god, and the ultimate response is like, "You need to see this other person," and the other person is like, "You need to see a third person," and then the
Like,
third person sends you back to the first one, and you're like, I've been going in circles right now."
it's
Yeah.
yeah, it's not great. I will say as someone who is not is actually in the same system as I was in residency, it hasn't been too bad. I feel for my co-fellows because who are, like, having to I don't know for you, but for us, it's like there's technically 3 different systems we're, like, rotating in, and so I only had to, like,
Mm,
get acquainted to one of them that I wasn't yet in.
gotcha.
But they are coming into the system, like, just fresh. So there's, like, many, many duo authentications they have to do.
Death by duo two-factor authentication, really.
Yeah. Well, and then they'll do the thing okay, and this is boring, and then we'll get on to pain, guys, sorry. This I'm gonna cause you pain with
This
boredom
is
first. I'm gonna induce it. Um, you'll do the thing where you go to orientation, right? Like, they'll bring you to the computers, like, "We're gonna get you, like, badges and logins, da 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 da," and when you're at the hospital, you're on their, like, verified network, whatever, so you can, like, get into all their website, and then they're like, "Yeah," and then when you get home, just, like, log on through a VPN. You're like, "Okay, this is great." But then when I tried to do that, it came up with something else that was like, "You aren't actually registered in Duo, so you actually can't do it on your internet." I was like and trying to explain this verbally via email to, like, the person in the, like, the registration office is
Yeah, dude, I feel like I'm at the car shop, and I'm trying to explain the engine noises that my car's making, and they're like, "Well, is it a camshaft issue or is it a modulator issue?" And I'm like, "It's going Can you fix that?"
they're like, it's like you're
I'm
at the
clicking
car
the
shop
box, the thing is
person
not working.
it's like you're at the car shop place, but neither of you are a mechanic. It's like this is like a third party software that like this is one of their many hats they wear, understandably. So they're like, I don't know why the software is glitching on
Mhm.
you. But other than that, good. Excited to treat some kids eventually once I get authentic and
No,
genuine
you're
everywhere.
doing your true passion, which is admin work, and then
My
then
tr-
the treating the kids will just get in the way.
yeah. I'm just trying to be an admin.
Dear audience, yeah,
I'm
Margaret's here to click
that's
boxes, don't get confused about it.
I'm gonna be the arch nemesis of everyone. Just kidding. I love admin. Couldn't
It
do
sounds
it.
like all of this onboarding has been a huge pain.
Yeah, you might say it was a pain in the neck. Speaking of, are you ready for the first part of this Our Chronic Pain, kind of part 2 episode, where I have some myths and truths about pain that I wanted to fast round test you on and judge you on your answers. No, we'll give the
I
answers
know
and then
you'll judge me anyways, I do that.
that's true.
I was reading the run of show, and it was like, "Now after we've reviewed what Preston got wrong, let's move on to the next section." I was like, "Okay,
Did
no
I say
faith.
that I
No
write
no
that?
faith."
Okay, but whenever I'm writing I'll like listeners, I'll be we have a document that we share with our producers that is like our run of show. And half the time when I'm doing it, I just see your little like Google face like meandering and you're like your your little like mouse will like hop and I'm like, why are you in here when this is the one I'm doing?
Enough.
And
On
not
to the
get out
myths
of
and
here.
truths.
Yeah. Okay. Before I ask you that, what has your experience been with treating chronic pain in med school? Like, how much do you think like lectures, rotations, whether in residency or med school, do you feel like you got?
I've probably had like 3 or 4 hour-long lectures, from either like anesthesiology or palliative care or family medicine, some form about treating like chronic pain in different contexts.
hmm And what's it been like as a resident? Like, do you feel like you've run into it in consults at all when people are like, this is addiction for psychiatry? And then you're like, they're actually just being treated.
Yeah, so how we run into it in, consults most of the time is like we have a patient who has chronic pain and they aren't getting along with their treatment team and there's some kind of like conflict there, and then they tell somebody somewhere that they're suicidal, and then the team is just like, consult psych. And then I go and talk to them, and they're just like, well, I'm just in so much pain all the time that I'd rather just not live than live with this pain.
Yeah.
And you're like, okay, well, so like your suicide safety plan is like treating your pain then.
Yes.
And then you end up
Yeah.
just being this giant circle where I'm like, okay, back to the team, treat the pain, you know. But I don't have any other like tools to help out besides my safety assessment, which was coming to the miraculous conclusion that people don't want to live with pain.
Yeah. Well, I think that's like a really great example of the kind of like interdisciplinary care that these kinds of patients need, both from an evidence-based treatment perspective and just like logistically. And on consults, it's kind of the worst setting for that because they come into the hospital, they need to get out of the hospital. The hospital doesn't want them there for beds. Medicine doesn't want to start a pain med. We aren't going to start a pain med in a lot of these cases. And the pain meds that we would prescribe aren't going to help right away. So I think that is a situation that anyone who works in healthcare will probably relate to of like, well, what do we do? And also probably patients who have chronic pain who've experienced this frustration of being shuffled around different care settings. So are you ready for our true or false?
Oh, I'm ready.
Okay. It's not in any particular order, and you may surprise me and get all of them right. I tried to make them a little difficult, so I didn't give you basic ones. If that you should
Okay.
take that as a compliment. You can only say true or false, and I will tell you if you're right or wrong. And then after we take a break from this, we'll come back and talk more in depth about them. Okay.
Okay.
Okay. Question 1. Nociceptor, aka the name for receptors for noxious stimuli and pain, come from the Latin term noci, which means to cut.
False.
Correct. Fibromyalgia is a type of neuropathic pain of the 3 types of pain as defined by the Stanford and American Association for Chronic Pain Guide in 2024.
True.
False. And Number 3, 30% of adults over 65 report suffering from chronic pain, and half of those people, per CDC estimates, are on pain medication.
True.
True. Correct. 25% of children suffer from chronic pain.
False.
True. The general first line of treatment for chronic pain should be physical therapy, followed by medication management when indicated.
True.
False. Graded motor imagery is one approach in chronic pain used to redevelop healthy nerve connections and brain organization to restore movement and diminish pain sensitivity through progressive invocation of imagined and enacted physical movement of painful body parts.
So, sorry, rated neuroimaging like biofeedback?
No, not biofeedback.
Okay, true.
If someone has chronic back pain, medication is not indicated for long-term treatment.
Pass.
No, that's not an option.
False.
Correct. And last question. Sleep difficulty and insomnia is one of the most common complaints in populations with chronic
True.
pain. Oh, he was on that. He's like, I work in the VA. I'm sure you deal with a lot of this.
Mm-hmm.
Okay, those are all my true false questions. I think you got 6 right of the 8. So you passed.
All right, we'll take
I
it.
think.
Yeah. What's passing? Over
Just
5.
and having a good time.
Oh my God, I passed.
Okay, so we're going to take a quick break, and when we come back, we will talk about these answers and then talk about a overall schematic for thinking about chronic pain as a psychiatrist, and for people who don't treat pain day to day. So we will be right back.
I have to study for Pride, and I haven't started yet. I just keep procrastinating it.
Will you accept some wisdom from me as your senior and as a fellow?
Oh, happily, Dr. Duncan.
I've been using Now You Know Psych to get ready for boards this fall, and it's a Q bank, but it's also more than that. There are flashcards, there's different ways to review topics, and it's been really helpful for me.
You know what? It is a great resource. Okay, Study Preston is coming back this weekend, and Now You Know Psych is leading the charge.
If you, unlike Preston, are ready to take your exam prep to the
I
next
will be
level,
ready.
you can go to nowyouknowpsych.com and enter our code for the podcast, Be Patient, that's one word, at checkout for 20% off. That's nowyouknowpsych.com, code Be Patient.
And use the code. It's 20% off, and then they'll know that we sent you. That's important. It
No, treat you
shows that we
right.
did a good job. Yes. So, one podcast that I think all medical providers should be aware of is the Sepsis Spectrum by Sepsis Alliance. It's run by this great critical care provider, Nicole Kupchik. One thing Nicole does really well is she captures the human story within infection. Anytime a person's involved, there's going to be a story involved, and she finds a way to bring sepsis outside of the hospital. And she helps experts tell the stories of patients who have sepsis in the community and teaches you how to recognize signs when there's problems to bring them into the hospital. We know that 87% of sepsis starts in the community, so it's important to make the conversations there.
If we know anything, it's that as many reps as possible, hearing as many iterations of presentations is how we recognize it better and more quickly. And this podcast can help all of us with that. And you can listen to the Sepsis Spectrum wherever you get your podcast or watch it on Sepsis Alliance's YouTube channel. To learn how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. Okay, Preston, are you ready to learn the two of them that I guess you knew
Yeah,
most
well,
of
I
them?
think so. To be honest, there were a couple that I was guessing at, and I was like, oh, nice, I got it right. I feel like
All
I
right, that's
answered confidently
honest.
on like three of those.
And we're doing an aphasia episode next week, and I'm not going to do any preparation, so that'll be that'll be me
Yeah,
next week.
you'll you won't be able to find words for that episode.
All right, well that's it. That's it for our episode today. No, okay.
Yeah, no, I thought it was hard. I mean, I appreciate the Latin, but I think I knew nociceptor came from something that wasn't cut. So that one I did feel confident about.
I knew you would know the root. I was like, he's gonna this guy. Okay, so you're right that noci is the Latin root and it means to harm. So nociceptors are what mo- so the reference for almost for all of these, and honestly the reference I go to a lot clinically is Stanford has a chronic pain guide that they put out every year, and it's like 200 pages. It's free. It's a PDF they have
Mhm.
online. They are now, as of last year, doing it in collaboration with the Association for Chronic Pain. So they are collabing on that. And so these questions and a lot of my like clinical based stuff is based on that as the most recent kind of approved resource. So first one, nociceptor.
Hard.
I like
Okay.
the the nerdy part of me likes knowing what all the receptors
Yeah.
are. Um, but it we'll get back to why this matters for one of the other questions. But yeah, so basically it is named after the receptors that pick up on pain or harm or noxious stimuli.
Mhm.
We will get into this that it's kind of complicated to think about pain and whether it always has a relationship with the noxious stimuli. When I say noxious stimuli, what does that mean to you, Preston?
Uncomfortable stimuli.
Yeah. To me, it brings up the idea of like tissue damage, right? Like something's
Mm.
physically wrong. And when we're
Mm.
talking about chronic pain, that gets kind of complicated when we can't find a reason or we can't
Mhm.
find the stimuli, but someone's
Yeah,
experiencing pain.
makes sense.
Okay. This one was interesting. I actually had forgotten this, but so number two is fibromyalgia is a type of neuropathic pain of the three types of pain. Um, this was one of the two you got wrong. I thought it was neuropathic as well, but it's actually a third type, which again, we're kind of in the weeds. We'll get more into the
Mm.
real clinical
So
stuff,
wait,
but
what are the types of neuropathic pain?
yes. So the three types are the three types of pain that they delineate kind of in the Stanford guide
Mhm.
because the treatments kind of delineate in this way. Like the three they delineate out is nociceptive. So when we were talking pain and noxious stimuli or tissue damage. So pain from
Mhm.
like if I cut your arm off,
Yeah.
um, that would be in their categorization nociceptive. So there is damage to the tissue around it.
Okay.
Neuropathic, which is damage to the nerve. Certainly you can have
But I
damage
thought you
to
said
both.
there's 3 types of neuropathic pain.
No, I said there are three types of
Okay. Okay,
pain.
it's just 3
Well,
types of pain that they
we'll find
describe.
out from our
So there's
editors
okay, I see.
if I
Nociceptive,
said that.
neuropathic, and then one other.
Neuropathic, and then the one that fibromyalgia and IBS is categorized as nociplastic, um,
Mm.
which is pain from an unknown kind of source. So neuropathic is like with type like complex regional pain syndrome, or like if you know about people having pain with like type with diabetes, right? As the nerve
Mhm.
gets damaged, there is pain from like kind of faulty signaling. Nociceptive is from like tissue damage, injury, other kind of
Like
inflammatory.
appropriate somatic response
Yeah.
to injuries. Okay.
Yeah. And nociceptive breaks down. So the tissue damage one breaks down into somatic and visceral. So somatic can be kind of muscle, joint, things like that. And then visceral being like organ pain. So if someone has, I feel like the one that comes to mind for me is like people with like
Like
Crohn's or other
Outback Steakhouse
inflammatory.
after you eat a ton.
What?
Like, after Thanksgiving when you're just like, "Oh, I ate too much," and then your
Yeah, I
gallbladder's
guess
going
that would
crazy.
be one.
Yep.
I was thinking of like illness, like pathology. So like if someone has like Crohn's or ulcerative colitis and they're experiencing pain in the
Mm,
organs,
gotcha.
but also you're
Or, like, pregnant. Imagine.
maybe. I don't know. I'm like very aware of our scope right now, so I'm like I
I feel
um
I feel like the pain with labor could be, like, close to visceral pain.
I think
Sorry,
so,
you're
but
right,
then
we should be
it's
aware of our
also
scope.
somatic though,
Let's
because then like with
yeah,
labor, it's like actually
okay.
not
We won't touch
visceral.
that then.
So I'm gonna get dragged in the comments for this episode and the last episode being like, no, actually, Preston.
Okay.
Um, anyway, I thought that was interesting because it gets to the point of like, where is the pain signaling coming from that is then coming into like central nervous system awareness and then being felt. So
Mhm,
that there's kind of these different ways of thinking about the damage and that I guess the signaling cascade, it ends up being important for how we actually treat it in a lot of ways.
mm,
The next question was 30% of adults over 65 report suffering from chronic pain. And half of those, or 15% of total adults over 65 per CDC estimates, are on pain medication.
yeah, I did know that, actually. That's a statistic that's gets kind of waved around a lot, and so I think I've just almost come to anticipate, like, patients of a certain demographic, like, it's very likely to have chronic pain,
Yeah.
in their past.
I think that what's interesting is like 1 in 3, like this is over 65, but then it was also true that 25% of children suffer from chronic pain. I think I think it was 20 to 25% based on different estimates. But if 1 in 4 kids and 1 in 3 older adults, and probably 1 in 3 to 4, like general adults, are
Mhm,
struggling with chronic pain, you would think we would get more teaching on it or ways of approaching it throughout medical school, but I think even more than that in psychiatry training.
mhm,
Like, not that we're gonna be the ones doing, like, a Botox injection or something, but for how common it is and how interlaced it is with our illnesses, you would think that we would get it would be more of, like, a primary focus for us in some ways, or at least
mhm.
I kind of wish that I'd had that.
Yeah, I feel the way about a lot of things that, like, psychiatry is interlaced with.
That's fair. That's very fair. Um, I found the kids one surprising. I would have, like, not I would have guessed, like, 10% maybe, and I would have thought that would be a high guess.
Yeah, that's why I guess. I was like, I don't think it's all the way up to 25,
Yeah, but
but yeah, it's incredible.
yeah. I mean, have you ever worked with treating kids with chronic pain?
Yeah, it is really challenging.
Yeah, I feel like there's a whole different set of considerations, similar to how, like, we think about meds differently for psychiatry as kids
Mhm.
versus, like, older adults.
Well, I've so personally, like, when I've seen kids dealing with chronic pain, it's a lot of it can be, like, somatization of psychiatric disorders.
Mhm,
And so, like, very quickly, you're treating this kid who has a lot of chronic pain problems, and it comes out like they have a pretty toxic situation at home or with their parents or anyone else. And then you
mhm.
start to realize that, like, these pain treatments aren't working because this is like this patient's response to their environment and everything else. And so, like, it immediately turns into this Jenga pile really fast, is what I found.
Yeah. Yeah. No, I think you're right that there's definitely these other components that can make it be a like, all of these things go into whether someone is sensitized to pain and how the pain is expressed and felt.
Hmm.
The next one, which you got correct, was the general first line oh, wait. No, you didn't. You got this one wrong. The general first line of treatment for chronic pain should be physical therapy, followed by medication management when indicated, and this one was a trap. Uh, but I think one of the things I learned so listeners, my 4th year in med school, I spent it with, an embedded pain psychologist, at in St. Louis, and we worked on like a primary care guide for treating chronic pain.
Mhm.
And one of the things that I found interesting was like the studies on the first step is neurobio education around chronic pain in particular. And that may sound sort of like,
Wait, and so physical therapy is step 2?
well, it depends on the pain problem, but yeah, yes, like anything is step two. I
Wait,
told you
so,
it was a trap.
okay, but that's like a dumb
No, it's not because
the
most
primary
people
treatment
don't
is
get this.
education?
When was the last time you gave a person? When was the last time you taught a patient about central pain sensitization?
I don't think I've ever taught someone
Yeah,
about central
exactly,
pain
and that's you're missing the
sensitization.
effective treatment. So I'm sorry. Yes, I told you. I said I laid a trap, and you fell into the trap. However,
Okay.
most people are not getting taught the kind of myths and truths about chronic pain. We'll come back to that in a second. But the last one was graded motor imagery is one of the many approaches that are kind of psychological. You said biofeedback, that's also one of them, and
Mhm.
behavioral for chronic pain. And then 7 was if someone has chronic back pain, medication is not indicated for long-term treatment. You got that right. You said false.
Mhm.
I think that gets us into an interesting question, which we'll get into with meds for chronic pain of using it and then increasing dependence on it versus using it as a PRN. And I think there's an analogous way to think about it as we think about it with like chronic anxiety disorders and benzos, that
Mhm.
it's not a never thing. It's just a how do we optimize the medications and treatment plan for someone and reduce risks as much as possible.
Yeah. These are safety nets and parachutes. They aren't our mainstays.
Yeah. And then lastly, sleep difficulty is one of the most common complaints in populations with chronic pain. You have
I
experience
I
with
I mean,
that?
I feel like that's half the time is, like, the initial complaint that comes through, and then you start to uncover chronic pain afterwards.
Yeah. No, I think you're right. And obviously sleep is indicated for us in terms of like who comes to see psychiatrists and then like what makes our illnesses like worse
Mhm.
or better. Um yes. So one of the things I want to, I guess, start with talking about is what is this like common myths that patients will have about chronic pain versus like all other forms of pain. Which cat was
Mhm.
that?
This
Uh
Lilac, she's on one
she's
today.
being crazy. She's a crazy girl. Um so how would you define chronic pain versus acute pain? Like is there a timeline you think of?
I would say anything under 6 weeks is kind of like my general cutoff for acute pain versus chronic pain.
Mhm. And the way that pain defines it is 3 months, more than 3 months is how that is their kind of arbitrary cutoff, but
Okay.
yeah, so pain that lasts a long time. I think the other part of that is what caused the pain, so, like, if I stub my toe and it still hurts 4 weeks later, versus, like, if I have open heart surgery and I'm still having some twinges, we might consider it different, so it generally is beyond 3 months, but also weeks to months beyond what you would expect in the normal healing process for a given injury or disease.
And then I think it tends to be more vague, the
What do you
way in
mean by that?
which so, I think people with chronic pain when they try to I try to kinda ask them to pinpoint where it hurts, and they have trouble saying, like, putting, their finger on the toe that hurts specifically. It's just kinda like, "My body hurts, this hurts," you know? I've just found I don't know how if that's a part of the criteria that you've listed, outside of, like, extended normal, ordinary healing processes, but
I mean, I think you can think of, like, let's say we have a patient who has, like, knee pain because he has knee osteoarthritis, right? And it's ongoing for years and years and nothing is making it better. We would probably call that chronic pain, even if it's super localized.
sure.
Another difference between chronic pain and acute pain um, is the functionality of it. So, one of the things that we think about in pain is like acute pain is the body signaling, quote unquote, correctly that there is something has happened. This is outside of things like fibromyalgia or complex regional pain syndrome, but basically it's like the body signaling that something is dangerous or the stove is hot and you need to stop or you're going to risk life and limb. I think all of us heard probably during one of those 4 pain lectures in med school about people born with like a genetic condition that makes them not sense pain, and they often die pretty early and have injuries because they can't feel it. Or we've worked with patients who have neuropathies and can't feel their feet, and we see their feet and they are not sensing the things that are injuring their feet. So pain has a function in our body that is protective, and acute pain is generally thought to be within that the alarm system is working well,
Mhm.
whereas chronic pain moves us into this concept of central pain sensitization, and into a sort of broken alarm system that it's not just someone's broken into your house and the alarm is going off. It's like anytime someone sneezes, the alarm is going off, and making you very aware that something is amiss, which is not as helpful for chronic pain.
Mhm.
Um, the last thing I'll say in terms of differentiating them, that is part of the many things you could say on neurobioeducation, is the differences in how you would encourage a patient to deal with acute pain versus chronic pain. So let's say I was leaning down to do play therapy with a kid, and all of a sudden I had a strain in my back or something, and I come and see you, and you're my doctor in psychiatry, and we're talking about other
Mhm.
things, but I'm like, "Yeah, things just been hard because 'cause I've had this back pain for a week since I strained my back." What would be the difference in what you would tell me to do with that versus if I had had the back pain for a year?
Yeah, so I think with acute pain, there's almost no discussion about, like, your relationship with the pain. It's really just, here are coping skills, or, like, what are ways
Mhm,
we can get you to survive until the pain subsides, and then you can
mhm,
go back to your normal level of functionality.
right.
But in chronic pain, I guess anything that I would counsel you on for acute pain wouldn't really work because the pain's not gonna go away. It's a roommate at this point. It's not a a temporary,
You have a
like, couch
roommate.
surfer.
Yeah, no, that's exactly right, and I think that's one of the core concepts that is helpful to explain to patients, but and more than explain, to kind of work with, because there is in the, pain world, you kind of variety of, like, let's say, injuries. You're exactly right, that someone's been in pain for, like, a week, you'd probably tell them, like, rest is probably good, like, take it easy, get enough sleep, don't push yourself too much, don't injure yourself further, wait till you feel better, and then get back at it or whatever.
Mhm. It's
Where
weight. Weight is at the center of it.
yeah, versus chronic pain, mobilization, functioning, kind of behavioral activation, and some tolerance of the pain, and like you said, how you relate to it are all central to getting them back into their life, done with compassion and done with like a graded kind of program. But
Mhm.
wait, ice, treat it, wait for it to go away until we start doing the next thing in our life is does not work and reduces function and worsens pain sensitivity
Mhm.
sometimes. Does that make sense?
Yeah, it does.
I think the other thing with just to touch on pain, central pain sensitization, the broad idea we talked about this in our pain episode with Lady Spine Doc, but it's generally the idea. I'm going to oversimplify it into a metaphor. The alarm is going off somewhere in your body for long enough without stopping that your central nervous system picks it up and is like, okay, instead of tamping it down, it just makes the central nervous system sort of be on high alert for pain in that area, but also then in other areas of the body, which is
Mm.
part of why when people have one chronic pain syndrome, they're more likely to get others because
So
there's this centralized process of sensitivity to pain, not just at that nerve site, but now within the central sort of processing and inhibition and disinhibition of pain signaling system.
I see. So it changes, fundamentally changes the signal to noise ratio that
Yes.
your nervous system is working with.
Yeah. Yeah.
Interesting. And so, this is all sympathetically mediated. I guess just thinking out loud, exercise is a great way to induce norepinephrine modulation of
Mhm.
muscles and joints, and then also of the medicines we use, SNRIs or serotonin norepinephrine reuptake
Preston, you are
inhibitors
segueing us perfectly into
are
our
great.
medication
So things like
approaches.
venlafaxine and duloxetine are quite
Yeah.
effective.
Yeah. So do you want to, so norepinephrine modulation more so than serotonin
serotonin. Mhm.
modulation.
Or even, like, opiates or dopamine or anything like that.
Yeah, I wouldn't speak to opiates, but dopamine, yes, because
Mhm.
there was a discussion on, like, Wellbutrin has not been shown to be helpful for pain. Stimulants for sure have not been shown to be helpful for pain. Um, but SNRIs have been shown to be helpful, and TCAs as a
Mhm.
class have been helpful, and it's attributed to the norepinephrine impact compared to just SSRIs alone. What are the
Interesting.
most common ones you think about? Like, do you have any that come to mind that you've seen patients on or that you've thought about starting for people with pain while they are in your psychiatry clinic?
Yeah, so, I mean, classically, duloxetine of the SNRIs is probably the most common one we use. Venlafaxine, not as often. From what I've seen, it has less of an effect size than duloxetine. I actually I've been kind of proven wrong, I think, over the last year. I used to have a lot of skepticism about duloxetine because I'd read papers about how much it actually helped people with their pain.
Uh-huh.
And the average pain rating, on patients that had whole regimens and then like plus or minus duloxetine, it would be self-reported pain of like 6.5, and then in the treatment group it'd be like 5.7. These are scales out of 10. So I was like, what is the actual difference of like, you know, rating your pain a 5 out of 10 versus like a 6 out of 10? And like it was over the course of, 1,000 patients, if that's the average change, like how many of these patients are like really going to be noticing that difference?
Mhm.
But anecdotally, I've seen a lot of people that, like, they find duloxetine does a great job
Yeah.
of, reducing their pain. And I think one thing that's unique about a lot of psychiatric treatments is that we get these averages that are spit out in our surveys, but the reality is in a lot of patients, they either work or don't work. So
Mhm.
so it's like
Mhm.
the average is like, half of a point, but that comes from it doing nothing for 10 people's pain and then doing like basically everything for the other 5 people's pain, and then the average comes out to be somewhere in the middle.
Right. Right. Yeah. Well, and, like, the fact that there's any significant difference on these studies compared
Mhm.
to we've tried, right, like, regular SSRIs, we've tried other things at
Mhm.
versus
And they have
placebo, and
no
they
effect
come
size.
out in the
Yeah,
wash,
nothing
yeah.
detectable. Yeah.
Um So, yes, I agree with you. It's definitely not the cure all. It's generally more thought to be helpful for neuropathic pain. Um, and then TCAs, the common ones were nortriptyline, amitriptyline, and then milnacipran or Savella is FDA approved for fibromyalgia treatment,
Mhm.
and possibly more potent than others at blocking norepinephrine, which is an SNRI, I believe. Am I tripping? Is that?
I don't think I know the mechanism of that one.
I think it's an
It's an
SNRI.
SNRI.
Yeah. So it's thought to be possibly more
Mm.
potent in the norepinephrine field than
Super
duloxetine and
duloxetine.
yeah. But I've never prescribed it clearly because I was just like, "Is it
Yeah, me
SSRI?" But
neither.
I've seen rheumatology prescribe it and had a couple patients who had good impact from it. So, um, the other thing thinking about pain meds, not with SNRIs, but like TCAs from our view as psychiatrists, is just thinking about like, um for people 2 things. 1, if we're treating in the Jerry population or for anyone who's just very ill and struggles with balance or other things like that, thinking about, side effect profile in terms of dizziness, like hypotension, other kind of cholinergic burden, and then thinking about if they actually are on pain meds, to make sure we're, thinking about serotonin load if they're on an SNRI or a TCA, just because
Mhm.
some other pain meds can also be, serotonergic.
Mhm.
So those are our kind of, like, psychiatry's in the right to prescribe these ones, right? Like,
Mhm.
those are our kids, those are our meds.
Yeah, tramadol comes to mind when you
Yes.
talk about these other, like, pain medications, and
Yeah.
my rant about tramadol is
Oh,
that
I know
it's
this rant.
it pharmacologically is actually closer to venlafaxine than it is to codeine.
Mhm.
So, it's better to think about it as, like, an SNRI that has a little bit of opiate action rather than an opiate medication that has some serotonin interactions. Granted, it does have an active metabolite that is a lot more specific for opiate receptors and other things. But as far as like mood benefits and anxiety and pain is concerned, that's where tramadol kind of lives. I always find it so funny that, like, there'll be, people, like, family members will say, like, "Oh, I didn't need antidepressants. I just had to get my pain treated with tramadol, then my mood got way better." And you're just like, "Yeah,
Fine.
I mean,
Got treated with an
you're getting
antidepressant, baby
store
girl.
brand venlafaxine." And then and then when you stop your tramadol, they're like, "They're gonna stop my tramadol, and my mood tanked again." You're like, "Oh, yeah, I wonder
Crazy.
why."
Um, yeah. I remember I did a rotation with, toxicology. I feel like you could be a toxicology person. I mean, we can't. Can we as psychiatry go into tox?
I
I
have
don't
no
think
idea.
so. I love the toxicology people. When I did the rotation with them, every day was like them debating and doing a rant, and one of them was about tramadol, and then showing us the blog, The Tox and the Hound, that has an article called "Trama Don't," and I'm like, it
Yeah,
stuck so
trama
hard.
never.
Um, a couple other things that I think because we see our patients frequently, ideally, especially if there are therapy patients as well, we may be the ones kind of, like, talking with them the most, so I think just to touch on non-opioids that are, like, over the counter that our patients might be taking, and how their side effects can interact. So, what are you think do you ever talk with your patients besides the intake of, like, what the counter medications are you taking? Do you ever get in the weeds with them about this?
Um, I mean, I guess it varies by patient. So, I may ask them if they're taking other over the counter supplements or, like, what they're doing to treat their pain, if they have
Mhm.
any.
Mhm.
But, the one I will get into the weeds on will be Tylenol.
Mhm.
So, I think this was hammered into me from a lot of my family med rotations. UNC had a great family med department, and one of the things that they cared a lot about
Must
was,
be
like,
nice.
getting patients on scheduled Tylenol and, like,
Yeah.
helping them really it's almost like selling the benefits of, like, doing, like, consistent low-hanging fruit for pain management before escalating. Because I think a lot of patients will say, like, I'm really frustrated. Tylenol doesn't touch my pain at all, so I'm
Mm,
almost, like, unwilling to try it, and I wanna try something more powerful." But then you have to reappraise Tylenol and say, "It's not great at, like, killing your pain right now, but if you
and
take it at the same time every day, it can be pretty effective for at least, like, reducing the baseline and making it easier for the other interventions that we have."
yeah. Yeah. No, that is the one of the points I was gonna, like, make with this is, like, thinking about scheduling it. The only other parts I had to add was, like, thinking about, options for topicals that people haven't tried, although those are mostly based for, like, arthritis, but, like, we see it all the time in inpatient, but outpatient, like, we don't really talk with our patients about this, like,
Mhm.
lidocaine patches, Voltaren gel, thinking about whether a different like, whether them getting prescribed from their PCP, and this would be outside of our scope, but, like, um, different options based on side effects. So, like, celecoxib is a selective COX-2 inhibitor, so it can have less GI impact if someone's really struggling with that, especially if they're combined with our meds that aren't always, making them feel good GI-wise, and from the ulcer perspective for NSAIDs. And then thinking about their kidneys, if we are also, like, treating someone with lithium, uh, always asking about that. But I think exactly what you said of, like, thinking about with the patient, when are they actually taking it? Have they had time to get guidance for their own personal life? And if we're seeing them week after week, with how they're taking it, if it can be optimized.
Yeah. The other thing that I could do a better job of, but I guess I'm not, like, really in the PCP role is, like, if you counsel someone on diet and exercise, I think a lot of us are just like, "Make sure that you eat healthy and exercise."
Preston, you
You
gotta
know
stop skipping my you gotta stop skipping. We're not done with meds yet.
Oh, sorry.
Diva. Um Okay, psychiatric meds, a couple other just things that are a little outside a couple inside scope and then a couple outside our
Okay.
scope, but that we think about sometimes. Gabapentin is always one that we can
It's like a
prescribe.
Swiss Army knife.
It is, for neuropathic pain. It can also has some indication for helping people with cravings with alcohol use disorder. It's not great at that, but, like, again, if there's multiple indications, like, let's say someone has a history of alcohol use disorder prior, and they have neuropathy post, like, heavy
Mhm.
alcohol use, this could be one that could be helpful for both, as well as pregabalin, although I hope you gotta get ready to do your prior auth on that, unless it's fibromyalgia, but then Room probably should just prescribe it because they won't
Mhm.
get pushback that we will get pushback as I've experienced. And then there's some specialized things we won't get into in terms of like anti-epileptics, especially for trigeminal neuralgia and some indication for neuropathic pain. The last category I have is muscle relaxants, which we are not, I'm not prescribing, you're not prescribing, but that interact with our medication and with mental status. And so I think
Mm.
the basics of those are probably important for us to just be aware of. So recognizing Xanaflex or tizanidine is more for spasticity and MS. Muscle relaxants, the biggest common one is Flexeril or cyclobenzaprine,
Mhm.
which
What about Robaxin?
yes, that is another. Yeah, that's another one.
Okay.
My favorite named one that again we never prescribed these, but is Scalaxin. Just someone's like skeleton relax, which is generic as metaxalone. Um, And then technically baclofen is actually not a muscle relaxant, but and it's used for
Mhm.
neuromuscular spasms.
Mm.
Baclofen and Flexeril are not necessarily really recommended for general chronic pain outside of spasticity, um, and especially for long-term use because they
Mm.
can be, kind of sedating and can kind of reduce cognition function taken long term. But I think we should recognize them, especially if we have a patient coming in who's like, "Yeah, I just haven't been able to focus for the last, like, year, and I've just been really feeling tired during the day."
Yeah. Yeah, I don't think I appreciate, like, the side effects of muscle relaxers. I almost, like my relationship with, like, Flexeril right now is almost, like, diagnostic where, like, if I see Flexeril on their list in addition to this, um, anthology of other medications or, kind of giant list of medications, I'm like, "Oh, this is kind of a chronic pain situation." But then I don't think about, like, "Hey, is this Flexeril, like, helping with the rest of their cocktail of meds, or is it, like, one of many things that's probably contributing to their poor cognition or
Right,
sleepiness throughout the day?"
right. Well, and as we talk a little bit about the therapies, and one of the therapies for chronic pain is the model that I love and know, which is acceptance and commitment therapy,
Mhm.
is when we get granular with our patients about their pain and how they're experiencing it, maybe one side effect from one of these medications that we're not prescribing, like feeling more lethargic throughout the day. Maybe for one patient, it's like, it only really impacts me and I take it mostly at night, so it's fine. Versus for someone else, it's making it really hard to like get up when their kids get up and help them get ready for school.
Mhm.
And it makes them feel all sorts of guilt and a like sense of identity change. Then knowing that detail and knowing, like, working with pain if they're prescribing, but again, pain is still hard to see regularly. Sometimes it's
Mhm.
PCPs. Like, how do we engage with care to help them, especially given how intertwined pain and anxiety, depression are, and insomnia
Mhm.
can be a tool for us to know and be, like, more thoughtful, collaborative care clinicians?
So, what are your pointers as someone who has more experience with acceptance and commitment therapy about how to approach this with someone? Because I think I've found a lot of challenge in counseling someone on their chronic pain.
Yeah. So, I mean, I think one of the things you'll find this year, I know you've started to do therapy last year. Um, it's definitely not, I got, well, one thing I always say to my patients with pain is, I'm sure you've experienced a lot of frustration in dealing with this and living with this, and I can't imagine that. And you've probably had many, many treatments that have failed, and people who have wanted to wanted to help you, but then also maybe brushed it away or couldn't get what you're going through. So starting there. The second thing is always the pain is in your, I think I've said this on the podcast before. The pain is in your head and in your neurons, but so is the pain if I cut your arm off.
Mhm.
So
It's always in your head.
it's always in your head. Yeah. So I
Mhm.
think start and then saying like, and there are illnesses we're discovering now that we didn't have the tools to see why this kind of, different types of like inflammation or other things were happening, and just probably told people 10
Mhm.
years, 30 years, 100 years ago that they were making it up because we just didn't have the science for it yet. So I think starting with that, because some people have understandably some almost like minor medical PTSD
Yeah,
from
just like
trying to get
chronic
care.
invalidation from the
Yes.
medical system
Yeah. So kind of being like establishing your identity of like, I am a safe space without being like,
without being pandering or
yeah, and well, without also being like, and you should know I'm not an opioid prescriber. Like,
Mhm.
I will say that straight out. I'm like, that's frustrating. We can talk about your frustration towards that, but that is not my role or my recommendation. Um, I think from an ACT perspective, so ACT's kind of core pillars are mindfulness to the present moment, increasing psychological flexibility, and diminishing avoidance behaviors in favor of values oriented behaviors. So, when it comes to working with people with pain from an ACT perspective, CBT is also like the most studied in pain and is evidence based, and ACT in some ways is a descendant of CBT. So, CBT would work more around like different fixed beliefs. And that's not like, we're going to
Mhm.
have you think that your pain's not bad. I know you know this, Preston, but for the listeners, that is not CBT when done well with pain is not like, what if you just knocked it off and thought, this is actually good that I have pain? But it is getting more in the weeds. Like, I used to be someone who loved gardening and I did this every Saturday and Sunday all day with my kids. And now I can't because my back hurts so much and I'm never going to have that part of me back. Um, that might be a fixed belief where when we push at it and kind of say, is there a way we can get a chair out there? Or like, is there a way we can elevate a table so you can work on things and maybe
Mhm.
someone will need to help you, but da da da. So that is still part of CBT. Some of it, if we went further, would have been like, what do you value about gardening that the pain's getting in the way? What is the type of person you are? And how do we, instead of totally giving up gardening or avoiding any try at it because it's might induce pain, do kind of a graded exposure work where we try little different experiments um, to live out that value still despite the pain. The other part is kind of mindfulness and compassionate acceptance. So, always on one hand, we're trying to, and this is true for all of our mental health concerns, like, always we're trying to optimize what we can from a neurobio medication and intervention perspective. And the pain is still here. And for many people, will still be here, ideally at a reduced like intensity. But how do we not spend every day fixated on like, is my pain going to ever go away? Why aren't people treating me correctly? Da, 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 da. And all of this really
Mhm.
happens over sessions, many sessions. It wouldn't all obviously happen in one setting.
Gotcha. So the intervention isn't targeting, why won't my pain go away? It's targeting these false beliefs like my life is over unless my pain is at 0.
Yeah.
Statements like
Yeah.
that where so then you teach you can reframe and say, "Okay, um, what if your pain was at a tolerable level? Or what would a tolerable level even look like? Or have you considered that?" And then, like, you can still work on adjusting and treating the pain, but also now accepting how you can move forward with your life in the way you want to.
Yeah. I think that's more of like the CBT and somewhat, and I will say motivational interviewing is also used a lot in pain. Sometimes motivational interviewing is used before you ever embark on any of these like therapeutic interventions, because if you're like, I don't think therapy can do anything for my pain and this is
Mhm.
bullshit and like I need whatever, like it's every therapy session will feel invalidating, understandably. And there are people who like, I mean, you think of like sickle cell, like you think of like people have being mistreated by the medical system whose pain needed to be treated in a different way and for systemic reasons, and then other cases, scientific reasons it wasn't. So you definitely have to be ready, I think, for the therapies in some way to like have them work.
Mhm.
Um, the other things that I think work when you're like not formally doing therapy with someone but want to help them build up skills is like talking about, there's an activity I always do with people of like pacing. So for people who have chronic illness or chronic pain, often like they'll have bad days and good days. And on the good days, it's almost like they want to catch up with everything they miss on their bad days. But then
Mm.
because they overdo it in some ways, they set off this kind of cycle of doing a
A worse
ton
bad day, and
and
then a
then the
more intense
worst
good
thing.
day,
Yep.
and then okay.
So helping them find patterns and then learn how to pace is a huge part, I think, of the work of pain psychology. and then using these like emotion regulation, distress tolerance, mindfulness, and like values-based prompts to build out from there. But the first step is always awareness. So I'll send them like a graph that's like, can you fill this out for me for a week? Because I want to, you've been through so much with pain already, and you've been through so many confusing med changes that first I just want to start with us knowing where we're at. That's where I would start in
At the
outpatient.
beginning. Tell me about the first time you were ever in pain, and then silence.
Well, and then they one of the things is also mindfulness as stress reduction, which I know you're so good at. Uh, you're so good at mindfulness. And then the thing you had mentioned about lifestyle is the final part of this. Well, obviously referrals for all the things that are like interventional and pain clinic that are many, many, and we won't get into, as well as physical therapy. Um, but lifestyle, what do you tell people who are dealing with chronic pain? Do you tell them things, or do you, if they ask about like what are lifestyle factors, I guess,
Mhm.
that you think about if they asked?
So, I usually start by saying that, like, it's gonna be the obvious answers that, we all hear, and I kind of almost, like, make a joke about it where it's like, we spend all this effort doing all this science and biochemistry and studies to find out that the healthiest thing is what your grandma told you to do, which is eat your vegetables and go run around outside. And and that's in a lot of ways, like, the best advice I can get you, and then I'll say, like, I know it sounds really simple, but it doesn't make it easy,
Mhm.
because I think we often will conflate, like, simple with easy, but, like, complicated doesn't mean hard either.
Yeah.
Sometimes sometimes doing something and the idea of it are there's just a huge disconnect. So, like, for example, running a marathon is just it's pretty simple, right? You just left foot, right foot for a long time, but it's a really hard thing to do, and that's what exercise might be for you, and also, it's gonna make a big difference for your pain,
Mhm.
and a lot of people, it helps get them to a new level of function.
I mean, I think the biggest thing is like prescribing, like, is helping people actually come up with a plan and not just like a SMART goal. But I don't think as many people as we think know how to find the growing edge for themselves of exercise and similar back to the pacing thing, right? Like, and same goes with like, let's say you wanted to eat a different kind of diet because it may be better for your like inflammatory or autoimmune illness. I think you're right that it's like it is kind of these basic things, but I think the movement from A to B isn't like rocket science, but I don't think it's something that most people have a lot of experience doing in a way that
Mhm.
doesn't either punish themselves or be extreme and then lead to kind of on off.
Yeah.
And I think that's where our like background and our understanding of therapy can be particularly helpful with lifestyle change is understanding habit and behavioral change and helping them week after week slowly grow in an area that might be the most helpful for them, especially in pain. Honestly, it is exercise.
Mhm. Yeah, I think what I found I do a lot is I'll, like, do open brainstorming with patients about ways that they can move, and because, usually the initial statement is like, "I'll exercise more," and if you just say you're gonna do anything more, like, I'll tell you for free, you're probably not going to
Yeah.
unless you've, like, identified a specific time that you're gonna execute on that thing. Like like, just the statement like, "Oh, I've been trying to sleep more." Like, "Have you? How?" Like, "Oh,
Mhm.
I'm going to bed at 9." Like, there we go, we're making a difference.
I've
So,
been trying to make a better podcast.
yeah, any measurable goals
And I
there?
giggled again. Any SMART goals?
We'll pick, anything from soccer, walking groups, run clubs, hiking, and then
Mhm,
we'll say, "Okay, well, hiking more is too vague." Like, I'll, like, pull up on my computer, "Let's pick out a hiking trail that you'd
mhm.
like right now." We kinda go, "Oh, this one looks oh, no, I don't like this route. Okay, let's try another one. Okay, so, your homework is to go on, like, Sunnyside, like, Devil's Egg Crest 4-mile hiking trail and tell me how it is, and I'll see you next time." And if you don't or aren't able to, then we'll talk about, like, what prevented you from doing that. So, like,
Yeah.
either way, it pushes the therapy forward in a helpful direction, or we get to see some behavioral activation and some
Mhm.
benefit there.
Mhm.
So I don't know. My supervisors think it's funny. They're like, yeah, Preston likes to explore with like fantasy and imagination with his patients, and I guess I do that a decent amount. Where like I'll like literally pull up my computer and be like, okay, this new fantasy life you want to live, let's build it right now, like
Mhm.
Minecraft. But it ends up kind of helping make these goals in the future more concrete.
Yeah, you should get trained in ACT because that's what we do. We go through, like we have them do if you actually do ACT sessions, it's like we go through all the values in a certain area, and then we say, "You're at okay, how would you rate where you're at in this part of your life?" And it's like, "Well, what would it look like if this part you were living with like, what values would you live by? What would it look like if
Mm,
you were living at this out of 10?" And, okay, how do we go from not and then, like, what are the practices or values that you would have to be doing day in and day out to move your life that way? And then how can we each week, we talk about, like, are you living at that 8? And it's like, let's say that person wants to run a marathon or something. It
mhm,
wouldn't be that living at an 8 means that they're running the pace they'd be running and they're doing this much mileage. It's like, I'm doing the next hard step, which is doing couch to 5K this week, whatever. Um, so, I mean, I and other ACT therapists agree with your methods, and also I always end my visits by being like, and I'm gonna annoy you, I'm gonna ask about this next time." So, but I say the same thing of like, "And if you don't do it, that's okay, we'll figure out what made this, like, the assignment that didn't work, and it gives us data, it's a hypothesis."
mhm. You can't lose when you're collecting data.
That's so nerdy. That's merch. Um That's most of my things. I think something we didn't really get into, just we're at kind of at the end of this episode was many things we didn't get into, but just to talk about substance use and the understandable medication with substance, especially in the history of pain as the sixth or whatever vital sign, and the opioid epidemic in medicine.
I found almost hard more pressing for me these days has been marijuana.
Hmm.
A lot of people will self-medicate with marijuana, and then have mixed results on their pain, but
Mhm.
I've noticed it's been like, a challenging relationship.
Yeah.
And to be honest, like, I think I try to move slowly with people that have, like, a pretty strong relationship with their self-developed and reasonably self-developed coping skills, especially if they involve substances, but it does make a lot of other, like, pain management really tough, I think.
Yeah. Yeah, no, I think similar to our marijuana episode, mixed bag, mixed efficacy. It's not recommended um, necessarily broadly for pain at this point. In onc, it can be, and it can be useful for some people, but it's not. I think the kind of only beneficial kind of uh, ambrosia we thought it was going to be a decade
Yeah,
ago when it
I
first started
remember,
becoming legal.
from our marijuana episode, I even mentioned that, like, people have a hard time developing insight into, like, how their weed isn't helpful for them.
Yeah,
We
you're
got a
clip
lot of
farming again.
backlash on social media. I was like,
You're rage
"Dang,
baiting right now.
they really love their weed." Guys, like
We're gonna post this on the Instagram. You're
yeah.
rage baiting right now. Fishing for anger.
Dude.
Um, do you have anything else you wanna add in terms of things like you feel like you think about with pain or for your patients? We are going to have an episode with a patient and a fellow creator later this season
Mhm.
talking about chronic illness and I believe chronic pain. Is that right?
Mhm. Yeah, Alex Wilderson from Calling in Sick. So she's a creator. She has a lot of chronic pain and
Mm.
kind of documents her life and interactions with doctors. And so as she's been really I've been on her podcast and she's been really kind of fun to pick her brain and talk about like the experience from the patient perspective. So I think she'll be a great addition to this conversation.
Yeah. 'Cause
Um,
chronic pain is very much a team sport and picking up all these data points of like what does one person find works for their life, their values, and their pain is they are kind of they're in the pain psychology clinic, we would call them the quarterback of their team,
mhm.
um, which is a different emphasis than other parts of, You're probably not the quarterback in the OR when you're getting a surgery,
Yeah,
ideally.
yeah, exactly. Yeah, and I think, like, one thing we can talk more with Alex about is where the disconnect happens between patients and doctors, because one thing that we kind of talked about before was that there is this almost, like, this dance, and sometimes it feels like a protected game of Battleship where the patient is trying to convince you that they're in pain, and they're like, "What codified language can I use to convince you that I'm in pain?" And we're going back for, like, "What codified language can I use to convince you that weed isn't helpful for your pain?" And
Yeah,
and then at the root of all of it is kind of just an inability to see the other person's side, the other person's perspective, and then
yeah,
the
yeah,
antidote sometimes can just be, like, sitting down and be like, "Okay, here's cards on the table, this is everything I think, and here's everything I know and why," and then you can do the same, but a lot of that just comes from, like, starts with having a good relationship with the doctor that is managing your pain.
yeah.
And additionally is a really I think that was the other thing I wanted to get on, which is having that, like, quarterback in addition to yourself, I guess your backup quarterback being another physician
Mhm.
rather than what happens to a lot of them is they become pinballs in a machine
Yes.
where they
Yeah.
go see their PCP and they say like, "Oh, you need to see another doctor for that." And then you go see the pain doctor and they're like, "Okay, you need to see a different doctor to do the injections." And you go see the injection
Mhm.
doctor and they're like, "We don't accept your insurance." And you go back to the PCP and the PCP is like, "Oh, we could try this new different medicine, but like you should also see a therapist to talk about your pain." You're like, "I'm talking to 9 different people about my pain. I go through the same spiel every time."
And then you
And
get
then I feel like
acupuncture, and
I'm
they're the
lost.
one
I'm not getting
person who
anywhere.
listens to you, and it actually makes your pain better, and maybe the intervention actually makes your pain better, and then you tell your primary doctor that, and they're like, "Well, that's fake." And then you're God.
Yeah, yeah, exactly.
Um, I think the other but from the clinician side, it's like, how do we deal with our own impotence?
Mhm.
Like, and how do we not take that out on the patient? Like, I think that's, like, a big thing
I
every
think sometimes you
day.
just have to call it out. Like, I find myself doing that
Yeah.
more. I'm like, "Look, honestly, as a society, we're bad at treating pain." You lead with that
Right.
rather than just kind of trying to dance around the subject of like, "Oh, I'm just a bureaucrat and and
Yeah.
follow these appropriate channels for getting referred to a specialist to have your pain managed."
Yes. Yeah. Instead of answering their, like, I feel unheard by being like, "Well, this
You've
is what the science has shown." So, it's like, stop like, it's, like, not
Yes.
gaslighting, but it's like I'm deep in Love Island right now, and there was a scene where, like, this guy started a fight with one of the girls on the island, and then suddenly just, like, his face went blank, and he was like they were in the middle of, like, yelling at each other, and his face
Mhm.
just went blank, and he's like, "Well, if you can't, like, control how you feel or, like, if that's how you feel, I don't wanna talk about this." So, like, I think that's what we do sometimes as clinicians. We're like,
Yeah.
"Well, this is what the evidence shows."
I mean, we
Like,
put
"F you,
people in a
no wonder you'll
cage
get mad
until
at
they're
us."
they're so pissed, and then
Yeah.
and then by the time they're, like, get emotional and animated about it, we're like, "I need you to calm down," you know?
Yeah, and it's like, "Girl, you made them, no."
Yes. And then we're like, "Oh, are you
Not always.
agitated? Here, fill out this agitated questionnaire about how agitated you are." Have you tried filling out our unheard questionnaire
"Are you
about
mad
your
at me?"
pain?
questionnaire.
Yeah.
How mad
The
are
A
you at
mad, "Are
me?
you mad at me?"
You heard it for research,
Mhm.
breaking breaking research here on the
So
podcast.
much paperwork.
Oh, all right. Well, we hope that wasn't too painful for you.
Or chronic. We're keeping, our honesty with the timeline. So I guess in summary, chronic pain is very different from acute pain. It has to do with dysregulation of the signaling cascade lasting for longer than 3 months, and it kind of falls under these neuropathic, somatic, or noisoplastic types. We have lots of different medications to treat them, but, the ones that come to mind are things like SNRIs, some antiepileptic drugs, gabapentin, and then muscle relaxers are the ones we went through. In addition, we didn't really talk about treating mood symptoms, but depression can change how you interpret pain. So even just targeting depression itself can modulate people's pain. And then you have acceptance and commitment therapy to go through and help people cope with and also become willing to tolerate their pain in addition to the treatments they're getting. And then we try to counsel people with diet and exercise and giving them not just specific SMART goals, but also like events or goalposts that can be reflected on in the next session. And all this is in the backdrop, like we just joked about, of a super complex behemoth of bureaucracy that refers patients inside the jaws of the industrial medical complex that is America. And it's absolutely a nightmare to handle. And if you're a patient that has to do this, I'm sorry. And if you come across my clinic, I'm going to tell you that I'm sorry, and then we'll start working on your pain. All that being said,
Perfect.
thank you so much for listening. We always enjoy having you bring us along for the ride. That is either your car or your walk with your dog, or maybe you're just sitting on the couch. If you like the show, we want to hear about it. If you don't like it, we want to hear about it as well. We're always looking for new ideas. You can come chat with us in our fun. Oh, they changed the wording in here. Come chat with us in our fun human content podcast family on Instagram and TikTok at Human Content Pods, or contact our team directly at howtobepatientpod.com. You can always see more from me and Margaret on my YouTube channel at It's Presro, or Margaret's at Bad Art Every Day on TikTok and Instagram. We also have at How to Be Patient on Instagram. It's like Margaret and I's little shared Neopet. We're up to 2,300 followers now. So thank you, all of our
Big
super
ups.
fans out there. Yeah, we'll keep posting for
Join us
y'all.
while we're still an underdog story.
Yeah.
You can say you
Yeah,
were
you're
here
like,
from the
we
beginning.
knew them before 10K followers. Full YouTube videos will be available on each week on my channel. And then if you want to listen to us on audio, we'll be anywhere you can find your podcasts on either Apple or Spotify. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benz-V. To learn more about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production.
Bye.
How to be patient.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.